My talk today is on the role of FUT in what is predominantly an FUE world. The trends today is that we've really seen in the last few years a trend away from doing FUT, but that has also led to now a lot of FUE-only doctors where there are surgeons now that no longer perform FUT. So what FUE surgeons want you to believe is that you get these horrible scars that are terrible, but this is a scar that I created that you can see that's virtually invisible. What they don't tell you is that there's a real risk of over-harvesting and really an inability to correct this. This is a gentleman that had both multiple FUT scars followed by disastrous over-harvesting and exposure of his donor area with FUE. So what FUT surgeons, though, want you to believe that these grafts are look like this. They're terrible, but they're not. They're very healthy grafts. And the reason is due to hybrid technology and the oscillation of these technologies, which don't have the rotational shearing forces that the older harvesting techniques had. So survival today really is on par, and that's important to understand the propaganda on both sides. I want to focus this talk on SDA, safe donor area defined by Unger, as well as total donor capacity. So the question is, are we harvesting hairs outside of the traditional SDA? And I would argue, in general, if you're doing a large FUE case, that you really are. We don't know what that safe donor area is. This is an example of Bruce Willis in his 30s, where he's had a Norwood 3 advance now to a Norwood 6-7. And that is something, if he harvested FUE grafts way up into the crown area, for example, or higher up in that backside, he probably would have those grafts gone and visible scars. Total donor capacity of FUE versus FUT. In general, you have a range of 5,000 to 8,000 grafts when you're doing FUT. With FUE, if you're doing it, you have fewer grafts. And especially if you're having a moderate to density individual, I would say the argument is that you actually have on the lower end of that. And again, if you're harvesting in a very wide zone, that actually could be potentially unsafe. Now, if you're combining the two with FUT in addition to FUE, you probably have even more grafts. And then if you add beard or body hairs, you have even more grafts that are available. So the issue, though, is what I urge you out there, if you are just FUE surgeons, that's all you do, is really respect total donor capacity, which is more limited than what you have available with FUT in general. There is a role, in my opinion, for both FUE and FUT. And so this is my algorithm, or just to have you understand some of the characteristics. High shingle means a hair stick out, low curl, this is like my hair, low density like here, short hair like mine, and high contrast. This is a great candidate. I would be a great candidate for FUE, because the problem here is that I could have a visible scar. FUT with low shingle, high curl, high density, long hair, lower contrast potentially in an older person would be more of an ideal for FUT. And you can see there's this intermingling where some candidates are going to be probably better for FUE, some better FUT, and there could be a hybrid between the two. So who are ideal FUT candidates? For me, women. I do 100% of my cases in women with FUT. Why? Because they don't have to shave the back of their scalp. You can take the sweetest spot of the hair, which is right in the center, rather than harvesting poor temporal hair to try to get the best results that you can. Also, when you do a wide, large area of FUE, there's oftentimes a palpable reduction in the thickness of the hair, and women obviously don't want that. So you get the sweet spot, no shave. It's, to me, ideal in almost all women, of course, with some exceptions if they've got tight scalps, etc. But women are ideal FUT candidates. Extensive baldness. These are candidates for FUT. Why is that? Simple numerical understanding of pi r squared. When the radius of that area doubles, then you're going to have to use 4 times 2 squared, 4 times the number of grafts to do that. And as I told you, that's an issue with total donor capacity already limited in FUE, and now you're trying to create a heavy burden on someone unless they have a really good donor capacity, but then you also butt up against a safe donor area where that is now encroaching on the safe donor area, because with FUE you have to harvest such a wide zone. So there's really a lot of problems when you're doing these large crowns with FUE, in my opinion. White hair, you have a really almost invisible scar. So this to me is, and it's so much easier with FUT, this is a great candidate for someone doing FUT. So it's a spectrum. You know, I see some candidates that are great FUE, some candidates are just great FUT that make no sense in FUE, and there's this gray zone. And I try to give my patients that counsel, and if I don't give them the informed consent, the pros and cons of both, and if you don't perform both procedures, you're going to sell everyone one or the other, whether it's FUE or FUT. So here are some clinical cases. This is an FUT scar that I corrected with FUE. This is a traumatic scar that I corrected with FUE. This is a patient that I think is not a good candidate for FUT. This is a FUE patient that you can see with short hair, relatively limited loss, great candidate for FUE. African American gentleman, more limited loss, he's got short hair, great candidate for FUE. There's a gentleman that wanted FUE, great candidate for beard transplant and eyebrow transplant using FUE. This is a gentleman that I think is a great candidate for FUT, very extensive loss, total donor capacity, SDA issues that I talked about, is a great candidate for FUT. This is a FUE, poor FUE procedure that I corrected with FUE. This is a gentleman that had 2 prior FUTs that were not good, and I corrected it with FUE. This is a gentleman that had a bad FUT that I corrected with FUT, taking the sweet spot of temporal hair that was not touched and beard FUE to get the right density that I needed. This is a gentleman also that had prior poor slot grafts, prior poor 4mm grafts, punch grafts, as well as a slot deformity in the back that I corrected with, again, perfect temporal hair with FUT to get the density, along with beard FUE to get this result in a single session. Women, as I said, female hairline lowering as well as density are great FUT candidates. So when all you have is a hammer, the world is a nail. You must have the ability to perform both, in my opinion. So advantages of FUE, there's less visible scarring if you're doing really short hair. There's a great psychology, which is there's no incision, faster recovery for athletes, potential additional donor areas like beard and body. It's a great complement to FUT when you combine it, and you can cherry pick the best grafts with FUE. However, that does lead to a faster donor depletion. Advantage of FUT, no shave is necessary in women, when people that have already had a prior FUT, for example. Better preservation of the palpable thickness of the donor area potentially, easier social recovery in certain circumstances because the sutures are hidden. There's an increased total donor capacity in the majority of patients. They can be combined with FUE, and it remains potentially safer in the SDA. So my textbooks, I make no money. They all go to stop sex trafficking in the world, which I think is a horrible crime. But I write about both because I think both are important. I really think the future is up to us. I run one of the few meetings in the world that talks about both FUT and FUE. So when you see the sea of people out there that you can operate on, if you're just doing FUE, you have a limited number that you can operate on. Summary is really understand the pros and cons of both. Understand that FUE has a more limited total donor capacity and a risk toward global thinning. And so those cases where you have women, older, white hairs, extensive baldness, prior FUT and reconstruction can be possibly done much better with FUT. So an FUE cannot solve everything. I encourage all the surgeons out there to be having both in their tool belt. And the future of FUT is not up to the patient, it's up to you. As incoming president of the ABHRS, I encourage you to become a diplomat if you can. Thank you for your attention this morning.